have probably gone to the previous sessions on the minimum operational data set for social care. The program's been running for just over a year now, and we've had several iterations of the minimum operational data set. So the presentation today we'll do a little bit of context setting again. I apologize if you've already seen those slides. And then we'll actually go through the gap analysis that we've done internally of the beta that was released in March, and try and collect a little bit of feedback in the session, and then go through what we would like from the community. So I guess without further ado, I'll dive into some of the slides, and feel free to put your hand up as the session goes along. We want it to be an interactive session, so yeah, if you do that, and I'm sure Jyoti will ping me and tell me that your hand is up if I can't see you on the screen. So in terms of the terminology product, so what this project is all about, so we set up Data.Digital Social Care last year, really because there wasn't a central place for the social care community to easily find social care data definitions, terminologies, data collections, data standards. So there are lots of really good bits of work going on across the system, but none of it had been brought together into a single place for the community to find what data standards were available. And see what best practice was for creating and managing data. We wanted this space also to be an area that people could contribute to standards development, and we've had lots of different users log in, give us their feedback. And then the third area was the project really wanted to work in the open. So what we've tried to do throughout this project is publish our work in progress, as it were. So I think every quarter we put out a version of the minimum operational data set and the kind of data specifications we're creating, and this really was a publication environment for us to start, getting that out there and trying to invite feedback. It's really three things then. It's tooling, so it's the website itself, it's the content, and ultimately it's the processes. So we've got some processes that we built into the tool that allow us to reuse existing standards, allow us to publish the standards and review the work that's gone on. So for us, it really gives us a place that we can curate content. It gives us a service desk where we can manage any feedback we get from the system. It says alpha there, I should have changed that to beta, so we're in the beta at the moment. And for standards users, it's really meant to be a place where you can find and understand the standards that are being published, that are being endorsed by the system, and also try and contribute to their development. So we'd really value your feedback throughout the process. So that's the terminology product. One of those bits of content, we had tooling, content, processes. One of the bits of content that we're working on as part of the terminology product is the minimum operational data set. So really, the minimum operational data set is something that was developed initially for adult social care assured software solution providers, to really standardize the way that data was captured and data could be shared across the system. Why is it there? Well, I guess firstly, we really want to improve the quality of care. We want to share best practice for data. Ultimately, it provides a common glue so that people are using consistent terminology and consistent data when they share information, because we know there's lots of different care actors involved in the care system. We wanted to create some consistency across data returns. So I think there's a realization that potentially there's burden across different collections that come from different bodies, and we want to make them as consistent as possible. So that gets into the reduction of burden, so reduction of duplication. I think when we started this process, we did an assessment of the health data models that were already out there, so health data standards. And although there were some high level models that we could definitely apply to social care, the feeling was they needed to be modified because social care works slightly differently from healthcare, and we needed to make sure that whatever we were putting in place reflected what was going on, not just kind of using different models from a slightly different way of doing things. We want to stop reinventing the wheel so that when someone comes in and looks at an assessment, we realize that different organizations have slightly different processes. But I think there's a lot of effort that goes into building a system and coming up with a specification. And actually across the system, people are doing providing care in mostly similar ways. So we don't want this constant reinvention of the wheel. It's inefficient. And it also means that it's then very difficult to integrate innovative assisted technology, because if you have to have your technology work differently for every single provider, that becomes very, very inefficient, and ultimately, lead to a reduction in costs, both for reporting, but also building kind of pipelines and integrated care systems, so you don't have lots and lots of point solutions. So I think that covers, and again, I apologize if you've seen these slides, but I think that covers the kind of why are we developing the mods. I guess we wanted to engage the community, and that's really what this event's about, and the series of webinars we've got over the coming months. So I just thought I'd very briefly about what we've done so far. So we had a discovery phase at the beginning of last year, and we spoke to around 100 people across professional bodies, advocacy groups, CQC, DSCR assured suppliers. And off the back of that, we created the first version of the mods and the first version of the terminology product. We also engaged with social care practitioners, so prescribers, providers, and people across occupational health therapy, adult social care. And we tried to invite participation in the development of the conceptual model, particularly around those areas. Off the back of that, we did some webinars in November. And we did a webinar on the mods and on the data catalogs that we'd created. We then did a further iteration in January and had really good attendance for that iteration as well, and got lots and lots of pieces of feedback. We then developed a conceptual model, and again, we had a series of webinars between February and March. And then we had another webinar in March around the beta that we delivered. And we've captured a lot of feedback through that. So we've had over 1,000 separate pieces of feedback from the community in the development of the tool and the development of the mods. We've done a lot of live polling, and we'll try and do some live polls today. So I invite your participation. It would be really, really helpful to get a little bit of that. And then we've had kind of targeted interviews with assured suppliers as well, to see what they think of the specification, how it fits with what they're currently doing and the way that they're building data models within their systems. As well as that, we've obviously been talking to and engaging with the central CTO team within NHS England and the standards team as well. In terms of our plan, so over the next couple of months, we've got a consultation period, and during that, we're going to have essentially 4 webinars on different topics. So the first topic is the one for today. I will get to it soon, which is about care actors, assessments, and care plans. We've got another topic coming up at the beginning of July, so on the 5th, that will cover observations, risks, needs, safeguarding, etc. There's quite a few observations that are included in the model. Topic group 3 will be about the administrative data, consent, legal information, and audit information. And then topic group 4, which will come at the end of July, will focus on instructions, activities, and actions. And again, it'll be about the webinar, but we'll also be providing some feedback forms. So throughout the consultation period, we're really inviting people to tell us what they think works well, but really tell us what doesn't work well, because that's what's going to really help us, develop this iteration. We're working towards a draft standard towards the end of August, and then we're working towards a version 1 of the standard in October. You can see the plan there. So we're on track with the current plan, and really it's all about getting everything ready for that October date. So today, the agenda really wants, I think that's hopefully sets the context, because I know it's been a while since we did the last webinar. So I guess I'll talk a bit about what we're asking for. So during this consultation period that's coming up, these webinars and the feedback that we're asking people to provide, talk a little bit about what we're asking for the community. We'll go through the mods specification and conceptual model briefly and show you what the findings have been internally from the beta, and present that gap analysis, and then try and provide a survey, not a survey. So without further ado, let's quickly. So if people haven't found it, if you go to data.digitalsocialcare, and you scroll down, there's a link on the front page for the minimum operational data set. There's some high-level information. We've got a few parts of it. We've got a needs terminology, we've got a risks terminology, and again, we'll be iterating those. And then we've got the minimum operational data set itself, the beta. So this is where you can find some information. What we'll be doing is uploading all of the webinars here, so you'll be able to see the session today and some of the previous sessions, so you can go back and see the session from March if you missed that, where we introduced the beta. There's some high-level information and links out to associated media. So these are resources that hopefully allow the community to further understand mods. So what we've got a guidance document, and I'll briefly introduce that once my internet wakes up. So this guidance document talks a little about the mod's purpose, the background, and we've got some information on the requirements and use cases. Again, a lot of this stuff is in the webinars, but we're talking about, you know, what the scenarios are to deploy the mods, how we expect it to be deployed, and we'll be doing some further iterations on that. And so if you want some further background, I encourage you to take a look at the guidance document. We've also got a conceptual model, which we'll be going through today. But again, that can be found on the wiki or through, you know, through this associated media. And this essentially gives you a high-level visual overview of the kind of key building blocks within the specification, how they relate to one another. And then we've also got a repository for FHIR. Now, we've only started that work. So ultimately, when we talked about the benefit of the mods, is it's about being able to share this information across different parts of the system. This isn't this isn't the focus of what we're doing now, but as the project develops, we're going to be trying to provide messaging specifications that not only looks at creating consistent ways to capture the information, but also consistent ways of sharing the information between providers and between kind of integrated care systems. In terms of the specification itself, you can go to assets and download applications. So we've got instruments, care plan, care actors. And what we've done is we've created feedback forms for each of those, and I'll talk a little bit about that because we're really asking people to provide feedback on each part of that specification. And then we've got the actual specification itself, and that's what we'll be going through today. So the two areas we're going through today are care actors, and you'll be able to see there's a number of different actors included here. So for the subject of care, for instance, you'll see there are a few different areas. So we've got the person's address. Within that, we've got a model for the person's address and the address type. We've got person's contact details. And again, we've taken a standardized model for that. We've got things like person's demographics, date of birth, gender, ethnicity, religion, sex. And if you go in and click on any of these data elements, then we've got a set of kind of consistent terminology that's usually come from an existing standard that we're asking the community to use when they capture that type of information. So this is the the system that we're using to share the information, so I'd encourage you to go and explore that. But that's probably something to do in your own time. What I'll do now is I will go into the feedback forms. So essentially what you'll have in each feedback form is, and actually it's probably just easier to show the forms themselves, like this. And so for a care needs assessment, we've got a number of different data elements, so bits of information that we'd expect to be captured for each class of information. So when you've got an assessment, you'd expect an assessment method, maybe a checkbox for child to adult transition, checkbox for community health check, the date that the assessment was made, if there's an EHCP in place, indication of mental capacity. So there's a whole load of information that you'd expect. And then what we're asking the community to do is, your ones will look a little bit different from this, is kind of give us an indication of how important you think this is for the delivery of care and the effort it will be required to implement this specification, and any other comments. And this really is to try and get a gauge of the impact and the burden of this. And again, we'd encourage you to go through and fill all of this in. I realise there's a lot there. Even if you just go in and make comments on the things that you think are particularly important, that would be really, really helpful. So if there are parts of the specification really that you think are, you know, have really, really high burden and basically don't provide that much value, please do tell us through the spreadsheet. And then you can upload it or send it through to us. So in terms of that process, there'll be some links to the presentation. I'll send them. Actually, you can go to our service desk and create a ticket, and again, we'll send the direct link through, but you can submit feedback for the mods and you can upload those forms. And again, we'll send those forms through to everyone. You can find them on the website. But ultimately, yeah, if you want to get it back through the process, then there's a form here that you can fill in. So for each data element, we're looking at the impact of it. So high, low, will it be burden, will it be difficult to collect, and then any other comments. So how am I doing on time? Okay. So I think in terms of the gap analysis, these are the three kind of main areas we'll be covering today. We'll be looking at the subject of care, care organisation, carer, personal contact, care professional, and proxy. Within care actors, in assessments, we'll be going through about me, needs assessment, risk assessment, mental capacity assessment, and then the care plan. We'll look at the care and support plan, additional support plan, contingency plan, and the end of life care plan. And yeah, feel free to put hands up and stop as we're going along. I'll start with the care actor conceptual model. So essentially what we've tried to do is a high level blueprint for care actors. It's based on ISO 13606 and CONSIS. But really what we're saying is there are kind of two major care actors. You've got organizations and people, and they're part of care teams often, and they provide care essentially to the subject of care, and they've got various different roles. So a person in one context could be a personal contact, in another context could be the subject of care themselves. So really those people and organizations have different roles in different settings. So an organization could be a healthcare provider, or in one context, but could be functioning as a local authority kind of in another context. And then you've got care workers and care professionals, health professionals, volunteers, and local authority professionals as well. And again, those are roles that are applied to those different care actors. In terms of the main care related. We've got care workers providing care for the subject of care. We've got the carers providing care for the subject of care. Both the subject of care and the carer are ordinarily a resident in a local authority, and there's some obligations of the local authority that are relevant for that. We've got our subject of care who could be taking decisions on behalf of we've got our subject of care proxy who could be taking decisions on behalf of the subject of care, and then potentially personal contacts. So that's the kind of, I guess, general model that we're trying to work to. So next I'll dive into the specification itself for the care actors. But I guess before we start, we just want a really kind of high level view for anyone on the call who has explored the model itself. We just like to get a kind of high level indication of the kind of whether you think the information is useful and all needs to be there, and the kind of burden of collecting that information. So Jyoti, I don't know whether it's possible to just put the survey up.
Sure, I'll just do that now. You should all see it now.
Those will just spend
Has it launched for everyone?
yes.
Yeah, okay, great.
Great. So we'll give it another got 7 responses. I'll give it another 30 seconds or so. And I think we've got some comments in the chat. So while we're going through I think the questions we've got in the chat are, could carer be changed to unpaid carer? So I think the definition we've currently got for carer is 100% unpaid carer. More than happy to log the comment. We've had kind of a lot of back and forth on terminology in terms of what we use as titles for these things. I think it's always going to be split, but we'll definitely take on the feedback. And but definitely the definition, if we go to carer, is an unpaid person who provides support, who looks after a family member. So that's 100% right. And then is an unpaid carer class as a care actor? Yes, definitely. So they're a person who is part of the care system, so they're definitely one of those care actors. So we've got quite a bit of information around the subject of care. So we've got a whole load of information about the person's address. We've got potential information about the death details, if that's appropriate, which uses the standard national model and things that need to be provided. We've got the person's demographics and the kind of key elements from the Equality Act.
Can I ask a quick question?
Sure, of course, yeah.
I was just wondering, so we're developing a DSCR solution. We've developed a DSCR, and so when I look at this, my question is that is the expectation that software suppliers will implement the entire standard, and what if your solution only covers a subset of that particular data set or whatever? So because that kind of reflects on how difficult it would be to implement, because some of it seems quite prescriptive in terms of the data required and so on.
Sure. I think it's a good question. So that's the first, it's one of the first general points in the gap analysis. So the big thing that we need to work on is the multiplicities. And this is kind of why we're looking at the impact and burden of each of these data elements. So if it's possible to provide that information back to us, that will be really, really useful. What we'll do in the next iteration is we'll say what is 100% important. So the difference between things that are mandatory and things that are required and things that aren't required. And then you'll have a really clear indication of what would 100% be expected, and what we would think that someone should be collecting, and then what's kind of more of an optional element. I think what ultimately these are building blocks, so I'm not expecting everything to be applied to every single system. But what we're trying to say is that if you are collecting an address, for instance, I mean, that's not good because that's in the gap analysis, but if you are collecting demographic details, we would expect you to collect things like ethnicity, and there's the ethnic category codes 2001, there's now 2011 that hasn't quite been rolled in. You'd be collecting languages in an ISO format. We would expect information on gender, and that would be using the standard coding structures for it. So point one is we'll be making it really obvious what's mandatory and what's optional in the specification. That's part of what we've been doing with the gap analysis. The second point is, do we expect if you do collect the information, we would like it collected in a consistent format, and that's really key, so that if we're sharing information on ethnicity or gender or language, for instance, we're all using the same terminology. So I don't think we've got time on the call now to go through the specification in detail. As I said, you can download the information from Data.Digital Social Care. You can go in and explore the specifications within the tool as well. I'll just quickly go through the feedback that we've had for each of these sections. So one of the bits of feedback was that we should be using a UPRN as an alternative to kind of the text-based address information. So that's something we're going to bring in. We've got links between organizations and actors, so things like ordinarily resident in. One of the bits of feedback is, do we need specific data elements within the subject of care specification that really point people towards collecting information on the GP and the general practice, general practitioner, specific data element for care providers and carers. We've got the ability to link all of these bits of information, but should we really call that out explicitly? And I think there were some areas where we didn't have drop-down lists or coding standards for things like languages and immigration status, and potentially we were going to do a bit of exploration around that. So that's what we found so far, and we're gonna we'll log all the bits of feedback we get on the call. So the next one is the carer. I think a few people have come up with, should we make this really, really explicit, have unpaid carer? We'll take the point back and we'll definitely have a discussion about it. Really, the carer, there wasn't that much feedback in terms of what we needed to do, but I think using an UPRN as an alternative to address was one area that we could probably improve the specification. Jyoti, is it possible to do the survey and just gauge, see if we can get some feedback on this one as well?
I'm sure. Sorry, give me 1 second. Okay, I have launched that.
So this is very, very similar. We've got the carer's contact details, which is a standard contact details model. We've got the carer's name, which again is a standard model for names. So first name, family name, preferred name. And then we've got the person's address. So I don't think there's that much in there. But hopefully it covers the kind of main bits of information that we should be collecting on unpaid carers. I'll give everyone a little bit more time to fill in the forms. There's 2 pages for each one. I think the key one is what level of effort will be required to implement the specification. I think for some sections, I'm hoping it will be lower than for other ones. Fantastic. So I think we've got 6, 7 responses, and we can leave that open, and I'll move on to the next. The next part of the care actor specification. So this again, this is not really much different. We're looking for a personal contact address. We're looking for personal contact details, and then we're looking for the personal contact name. So again, it's just we'll have a relationship between a person and personal contact, and this is what we'd expect to collect for them. So hopefully this won't be too controversial. Can we add the next poll, if that's okay? We're going to go through, I think, the first few fairly quickly.
I think I'll just have to close one poll, the one before, if you're happy with that, to launch the next one. Yeah.
Yes, please.
Okay.
I think we've got a comment from Steph around the mandation of some of this information. So we'll take the point, we'll log it. We'll definitely log that in the feedback log. What Steph said is that sometimes unpaid carers are less willing to provide their personal details. So maybe we need to keep a lot of that information optional. Yeah, presumably maybe the name would be made be required, but the rest of it potentially wouldn't be. Cool. I think there's a bit of a lag on the polls. I don't know whether it's just on my side.
Sorry, one second. So is it the care organisation you want, Adam, this time?
The personal contact.
Personal contact, okay. There you go. All right, that's launched.
Right. About 7 responses. So I think it's probably time to move on to the next one. Really, the survey is just for us to get high-level feedback on if something is really, really difficult to collect. We're going to have to focus on that. And we've got a number of kind of targeted interviews, which will also come off the back of this. So care professional. So I think the 2 bits of feedback, again, UPRN, time to address, that applies to all of them. I think there's a question about whether we actually need to break them out into different types. So at the moment, we've articulated a couple of different types of care professional. We've got care workers, we've got GPs, and we've got local authority professionals. Now, all of these, essentially, we're collecting exactly the same information for. So a care worker has a role, and ultimately, if they're a GP, there would be a code for the GP. So I guess the question here is, do we need to split these models out if they've got exactly the same information? And so far, we haven't seen use cases where we need to collect different information. This is taken from the PRSB model. So we've got a kind of role, a key worker, specialty and organizational name, professional identifier, identifier for a care team, the type of organization, and the organization identifier. One of the things that we might do as well is, rather than have an organizational identifier, we'll have an organization, and then this should be a link through to the organization itself. So if we go back to the care actor diagram, you know, that care worker would be linked to a particular provider. So rather than, you know, just focusing on the organization ID or the ODS code, maybe we should link to the model that we've got in the tool for an organization. And then you wouldn't have organization name, organization identifier, you just have an organization, and then you link to that organization record. So that's the other piece of the gap analysis. We've got a flag for key worker, specialty again, and maybe we'll get the, is it possible to get the survey up, JT, if that's okay?
Sure. Yeah.
Came up in some of the comments was there's quite a lot of information as part of the skills for care data collection, where they're looking at kind of training details and the types of qualifications that all of those care workers potentially could have. So we did have a comment was, you know, could we potentially integrate some of that information as optional attributes, so that if you are collecting those types of bits of information, you collect it in the same format as the skills for care format, so that, you know, that information doesn't have to be recorded twice on that. I don't know if we've got another. Sorry, JT, I don't know if it's just on my side.
Polls live on my side. Can you not see it?
I can't see it, but it might just be my side of things.
Can others see it?
Yeah, no problem.
Okay, cool. Well, that's important. Doesn't matter what I'm saying. So I think couldn't easily find out if the relationship could be flagged as paid, unpaid. This is to do with presumably to do with frontiers.
It's just generally between,
So-
generally between the subject of care and contacts.
Personal contacts.
Any contact. So HCPs are paid if you're paying a physio to come and help provide that care, but your niece or nephew might be unpaid, but it's still a relationship between subject of care and a contact.
So I think the kind of advice we had around that was that care workers are paid, carers and personal contacts are not. So the moment you become paid, you become a care worker, and I think that's in that's part of the Health and Social Care Act. So a carer is an unpaid person, and a personal contact would also be unpaid. And then, you know, they could be a personal contact, but have a role of care worker in a specific context, in which case you would have the record for the person, and then you'd have some information you would capture as part of the care worker record that's associated with them. But then you'd also have some information that would be provided as kind of as those personal contacts. Is that
okay? Yeah, that's fine. Do you capture how close they are so we can devise the relationship circle?
So we do have some information around the relationship. That's so we've got the carer relationship that shows the kind of relationship between the person and whether they're a household member. So we're capturing that type of information. Do you think that needs to be extended out to?
I think it's important to understand, for example, if you've got a contact which is your niece and they're really, really close, then they'd be the sort of people you speak to. But if, for example, they're what you'd think of as someone that they would be close to their spouse or, you know, their brother or sister, but they're actually quite estranged, you wouldn't normally approach that person for a discussion about the subject of care.
So I think it's a really good question. And there's actually, it's funny, I'm going to come back to that question no
problem.
There's two places.
Yeah, that's fine.
We could no, it's good that it's raised. So there's two places we could put that. We could either put that on the record for the person themselves, or we've also got that information potentially contained within the About Me section. You know, who's important to me, what's important to me, people who are important to me, and this at the moment is a high level narrative of the family members who are important.
Yeah,
I think this is
PRSB standard, isn't it?
That's the PRSB standard. Now, I think that information then could potentially be codified. So I think it's a good, I think it's a good. I think it's a good comment. We'll take it back and have a think about how we could integrate it into the model, because potentially that contact could have different relationships to different people, and so we need to qualify the relationships themselves. So the information would be contained on a specific relationship between two people rather than on the person themselves. So let's take that comment back and we'll have a think about that. So it's kind of it's a good point. And we'll go back and try and have a think about how we can bring that in, because I think it's important to codify it. It would be nice if it wasn't just in the narrative section.
Adam, it's Andrew. I just wanted to interject just to support you there. So this was discussed in some detail, I think, in the early stages of development of the specification, and it was covered by the About Me kind of information. Part of this is around implementation. So to say how you implement that relationship might be going too far in a specification, on around data items, etc. But if the relationship is there and the business need is there to show that, it might be a question of cross-referencing the About Us with the contact details, and then actually prioritizing that in the way that the software is implemented or surfaced to the user about that person. It's a really important point you raise, and we have discussed it in detail, but we'll have to take that one back, I think, Adam, as well.
100%. Yeah. No, we'll definitely log it and think about how the best way of doing it. Cool. So are there any other? I think we've got hands up. I think we've finished the survey for care professional. I don't know how we're doing for time. 48 minutes, so I think we're still on track. The next one is care organisations. So let's just have a quick look at that. And maybe Jyoti, if you get the survey going while we go through it, that'll give people a bit more time to do the survey. Thanks. So we've got three main types of care organisations. We've got care providers themselves, got the GP practice, and then we've got a local authority. I think again we could potentially just have a single attribute for care organisation. We're not going to be capturing all of the information about the care organisation, like the address and all of that other information. What we're trying to do is link into organisation identifiers, and all the local authorities, and it should be now the CQC providers get logged in ODS as well, and should have an ODS code. And so really what we're looking for here is a name and an identifier. So that was one of the potential pieces of feedback. I guess there's a question around should we be collecting location information for all of these? I think with the organisation identifier, there's a more general comment that every time we collect a code, should we also be making it very, very explicit when we store the data what that code is? Because although this says that it needs to be an ODS code within the specification, there isn't necessarily an explicit link to the coding standard itself. And if you're going to send a fire message, for instance, whenever you send a code, you need to send the coding standard. And so there's some, I guess, we're having a few conversations internally about how explicit we make that relationship. I think the types at the moment link through to the types at the moment link through to the skills for care organisations, but we could potentially need to make that a bit more explicit, rather than just having a link. It would be nice to have all of that information available immediately for the user. And then I think the last one was about CQC. I think we've at the moment got CQC location identifier included in the GP practice, but given that all the CQC location identifiers go through the GP to ODS now, is that just an extra bit of information that isn't needed? So I don't know if anyone's got any comments there. I think we've got the survey through. So let's we'll move on to the next section. So for subjective care, again, UPRN is attempted to address. You'll see that's a common theme. One of the things that was raised in some of the meetings was could in some situations proxies be defined by an organisation rather than a specific person? So we need to do a bit more investigation into that. I think it was mentioned at one of the recent standards meetings, so we need to look into that use case. I don't know whether anyone on the call but if you do, please send that through. Let's go through to the proxy for subject. And this is very, very simple. You've got the person's address, person's contact details, person's name. You've got the proxy's relationship. But again, this is more of that kind of high level relationship about parent, brother, sister, all of that kind of stuff. And then also a link through to the legal information that relates to the appointment of the proxy and the healthcare decisions that they can make. So that's just the high level. That's a link through to that high level overview, and to make sure that's captured as well. So I'll just wait a few minutes until the survey's finished. And then I'll move on to the next section. Cool. So I think there's a bit more here that we'll go through. So the next part is around the assessments. So I think just a note on this model, we're not necessarily saying that there should be one, big form that would include the needs assessment, the risk assessment, the strengths and assets. What we're trying to do with this part of the conceptual model is say there are certain building blocks which are around assessing needs. There's building blocks around assessing risks, assessing strengths and assets, wishes, preferences, strengths, around mental capacity. And sometimes these building blocks would be in a separate assessment. They'd all be done as part of a care plan, and that's what we're seeing in lots and lots of different places. In other areas, there would be a separate form or a separate activity where this would be done. So this is the kind of high level information. There's an outcome from that assessment. And then there's potential observations that then feed through to the assessment and the reassessment, and the different care actors who are performing the assessment, and potentially, obviously, the subject of care and the subject of care proxy, if relevant. So the care needs assessment. I think there's some kind of technical stuff that's probably, massively, but I'll go through it so that people have an idea. So we're in the assessment area, we're in the care needs assessments. So at the moment, you've got a link to the subject of care, and that's an explicit link saying you need to link that record to the subject of care record. But we've actually added performing professional as a subclass, so we should just, rather than having that underneath it, we should just have a link through to it. The location, and again, we've got the idea of a coded value for the location and some free text. I think the comment was, could we have locations that don't have ODS codes where the care need assessment happened? And should we have the coding standard for that location rather than just saying, okay, we've got ODS codes, should we have a list of coding standards you can use? There's the assessment outcome is another area. So at the moment in care needs assessment, we've got we've got the method, we've got some high level things that you saw, like child to adult transition, mental capacity, plan review date. We've also got the assessment outcome. At the moment, we've got this as a narrative. No, sorry, not a narrative, sorry, drop down list that relates back to CLD. But potentially this could be linked to the outcome class. So that's another bit of, and then the final bit is that we've got within the care needs assessment, we've got the needs themselves, and these coded values, the date they were collected, whether they're significant, urgent, who those needs relate to, and we've got a link through the coded values. But I think what we'll do is we'll make those available on the site so that they're easy to navigate, rather than having to kind of click through as you do at the moment, because that is, I think, a bit of feedback. That's the easiest thing to navigate. It does link through, but it would be nice if that was just that was just there rather than having to step through and look through those needs. Again, so we've got the needs assessment. That's great. I think people are getting probably poll fatigue, but we'll crack on. So about me, I think a lot of people have implemented this, and I think it's probably, I guess, kind of the bits of feedback we've had so far around it Or again, performing professional, should that just be an attribute and we look to the performing professional class? Location is exactly the same. Do we need coding standard as well as the coded value? And I think we'll take the points from this session, which is around, should we be linking those people important to me and qualifying those relationships and have those explicit relationships represented in the data? Because at the moment, most of that is available as part of the narrative. I'll move on to risk assessments, just in the interest of time. So I think the same points, codes and namespaces needed. I think definition for informed is something, and then risk reference data explicitly. So we've got our risk assessment here, and we've got the location. So do we need the coding standard as well as the coded value? Should the performing professional be a link through rather than going through it? I think we wanted a bit more of a definition for informed, our care actors informed, I think, of the risk is probably needed. And then within that risk assessment, there are a number of risks that would be logged. I think there's a coded value and the links through to the mods risks, and we want to make that more explicit within the specification so people can see what it is. We've got relapse indicators and we've got trigger factors as well. And then we've got safeguarding information as well. And that will relate to the contingency plan as well. So we want to be using the same building blocks within the contingency plan as the risk assessment. Sometimes they kind of happen at the same time. So I don't know at that point whether we've got to the team. I don't think we've got any more questions, so hopefully that will make sense. Mental capacity, so perform professional, should we link through codes and namespaces, and should we link to the outcome? Also very similar comments here. We've got you've got location of document, whether it's been performed, about the date that it happened, and then should we just be linking through to the perform professional and the person completing the record, and then do we want to have an outcome, which at the moment we don't have in there. I think it's one of the things we had within assessment model. We'd often have outcomes, so that was one of the gaps that we thought that potentially we should be logging what's happened off the back of that. Okay. And I think we're on to our final part of the webinar, so I won't keep you longer than you need to be here. So the last one's around the care plans. These are based off the PRSB care plans, and I think we've had a few conversations with the PRSB. So some of these gaps will go through a slightly different process, and we'll be feeding them back. Ultimately, again, this is really about the building blocks. We're not saying that there should be one form for a care plan. Potentially parts of those assessments could be included in that form, but the care plan needs to address needs. So it needs to be linked to those needs. It needs to address risks. It's probably that contingency plan. You need to have access to someone's strengths so you can evaluate them. There's usually a goal of that care plan, and then it will determine a number of instructions, activities, and then potential actions that happen. There's usually an outcome and potentially some observations that will be made about a person that should be feeding into that decision-making process. We need to log consent. and it can be, it's performed for the subject of care, but it could be expressed by a proxy as well. So we've got a few bits and pieces on this. I think, and these are a few things that I think are already kind of happening in the background. But we've got, let's go into it, and I'll just go through the care plan stuff. So we've got our care and support plan. I think the same thing around coding standards and namespace, which is general things like location. Should we have the coding standard and namespace? Should we have the link to person completing the record and performing professional rather than have those kind of subsections? Should we just have a link through to that model? Again, it's more of a technical thing. Again, should we have a link to strengths? We've got a kind of model for strengths. Agreed with personal legitimate representative. I think there's a class here. One of the things that we thought might need to be in there is the date that it was agreed. And I think this really is also very similar to our consent model, because you're providing consent. Essentially, you're agreeing to that care plan and providing consent for it. So there's a comment that maybe we need to align those two things. I think there's, and this is probably an open question to the community, because we've seen different things in different systems, and it would be great to get your feedback on it specifically, and we'll be doing kind of interviews around it. Is that at the moment there's within the care plan you've got needs, concerns, and problems, and those have your coded values, and potentially there's some alignment we could do between this one's based on the PRSB care and support plan, and there were some additional things that we had within our needs assessment that we saw in some of some of the solutions that we saw around scoring the need as significant or urgent, which weren't necessarily within this part of the model. So maybe there's a gap there that we need to align those things. The other thing that we saw, and I think there's different ways of interpreting this part of the model, the goals and hopes potentially could, your goals, your actions and activities, instructions could, rather than be kind of one need has a set of goals and hopes and a set of actions, activities, you could potentially have a goal and a hope that was associated with multiple needs, and so that relationship could potentially be slightly different. So we'd like just, I guess, a bit of feedback, and we'll probably be asking our assured suppliers how they're implementing this, just to get a bit more of a sense of whether this needs to be kind of a strict hierarchical relationship between all of these different things, or whether actually these are related concepts. So need is related to a goal and the hope, and is related to an action activity, and there are outcomes off the back of that. So I think that's those were the main bits of work we need to do, and I think that's just always needs to be a bit of alignment between when you're reusing standards. So I think that will happen. And yeah, and again, there's like actions and activities here. We probably need to take this information and add it potentially to other parts of the model where we're talking about actions, activities, and actions, to make sure that all of those areas are aligning. So again, there'll be a bit of focus to work on that. So that's care and support plan. I'll move on to the additional support plan, and it's really very, very similar types of comments, coding standards, namespace, link to person completing the record, link to performing professional. The plan is around the review. So both the care and support plan and the plan have a class for responsibility for review. And I think elsewhere we've got the concept of a review. So I think we need to, again, merge those two things. When we're looking at assessments, there is a review, which is a class that says who should be doing it, where it's done, what the outcome is, when it's scheduled, all of that kind of stuff. And here we've got responsibility for the review, so potentially we need to merge those two concepts and make sure that they're consistent. And that goes the care and support plan. It also goes for the additional support plan. So next we have the end of life care plan, and I think that's as well. We have the plan contents, plan review date the plan was last updated, and a link to the subject of care. I think to completing the record, we could potentially just link through to that. I think we've got some information on estimated prognosis. There was a question whether this could be coded. At the moment, there's kind of, there's a high level narrative around it, but potentially is there the opportunity to code some of that information? So that was one of the gaps that we looked in there. I think one of the things that we've seen here is there's some narrative around preferred place of death and preferred place of care. I think elsewhere in the model, we've talked about kind of wishes and preferences. And I think, this potentially should be aligning with those preferences and wishes. So I think there's a little bit of an alignment. Again, that was a bit of feedback we had when we went through all of the model together. And end of care and name. We've a coded value of free text. For instance, name of CT, but I think in general, if there's a ref set, something like that, should we be providing that? So we've then got the contingency plan. Well, we get the survey up. Back. So in the same way, the care needs assessment relates to the care and support plan, the risk assessment and the plan relate to each other. It's all about risks. I think on this one of the areas was, should we explicitly link to the risks in the risk assessment? I think there's a nod to them in terms of what are trigger factors, relapse indicators, and all of those kind of things, but should we be kind of calling out the risk potentially was logged elsewhere in the system and be relating back to that? Coding standard namespace, I think, is the same. Linked to person completing the record, linked to performing professional. I think again, those should be links. In terms of person completing the record, we've got, I think this is a general comment for the whole model, which is we've got a model for auditing all of this information, and part of that audit is that every time anything is completed or updated or modified, you need to link to the care actor who made that change and the type of change that it was. So I think we just need to dig into that a little bit more, because is the person completing the record the person updating or modifying it, or is it the person signing it off? And again, could we just include all of that in the audit information, we'll probably do that. I think there's some stuff around within the contingency plan. We've got some information about anticipatory medicines. Now there's already there's kind of models for medications. So do we want to be linking into the existing models that are there, or do we just want to be taking the kind of the codes that are out there? I think there's a bit more looking into that. Again, agreed with personal legitimate representative. This probably needs to link to the consent models, so we need to look at that. Yeah, I think in the advanced statement, it's also looking at those wishes and preferences. So potentially should be kind of be trying to link those advanced statements back to those. We also probably, given that these building blocks could be within the assessment process or within the care planning process, the care planning form, do we want to be representing that within some of the assessment information as well? Was also one of the bits of feedback that we had around the contingency plan. So I think we've got about 15 minutes left. I hope we've still got everyone on the call. I'll just let me just go back to yeah, the next section. So hopefully that kind of covers where our thinking is. So I think, you know, the beta went out, we've had time to review it, we've had time to talk to several different people about it, and we've logged the feedback we've got so far. And really, you know, we're now going to be running the consultation for the next month or so. So it's an opportunity for you to really add to that. So we'll send through the presentation and the high level view of what we've logged as bits of feedback, so you can go through and review that in your own time. Again, the links will all be here, so you've got the mods is here under this link. This page where you've got your data dictionary, you can explore that. You can also download your assets, and these are Excel spreadsheets, and we'd encourage everyone to provide feedback if possible. The conceptual models here, and that link will be in the presentation we send through. And then there's a service desk and a feedback link. That gets managed and logged and traced. We could send emails, but I think that, you know, emails sometimes get lost. If you do put it through the service desk, then it's logged. It will be broken up into different tickets, and probably actually the notes from this call will end up on the service desk anyway, so we can run through those. I guess yeah, I guess that's probably covers the content. So when is it likely to become mandatory to implement for software suppliers? I think I'll hand over to my NHS England colleagues for that. So we're looking to get a final version ready for October. But I think Alison is still working through the roadmap for when that will be mandatory. I think once, and Andrew, maybe you come in, but even once the specifications become final, then there will be, it's a year, isn't it? I'm sure before actually you have your implementation period before it's expected for the specification to come through. But Andrew probably has a bit more context.
No, I think you're more or less right. I think there's also the question about which components will be mandatory and which will be, you know, best practice, etc. So there'll be a combination of how your systems and the information needs to be standalone in its own right for good care delivery and good quality of care and experience. And then there's an element of what's required for integration purposes with other services, health services, etc., community services. And then there'll be an element of this which becomes, if you like, downstream, which is another year, which becomes mandatory as part of a data submission. through the 2012 Act or otherwise. So some of that will be linked to local authority requirements for providers, and some of it will be linked to other areas of health and care in terms of data collections, as opposed to direct care use. So I think you're right, Adam, that's broadly speaking, the actual mandatory component will apply initially only to the assured suppliers, but there'll be a sort of pull on the system for ensuring quality, continuity and integration.
So there'll be aspects which will apply to the assured to be on the assured supplier list, but then which would apply to software suppliers, but then there will also be other aspects which are required of care providers as part of their data submissions to CQC and so on.
Exactly that.
Okay.
Yeah.
Any other minutes, I think. I don't see any other hands up. If not, yeah, thank you. Yeah, I guess thank you for joining. Thanks for the questions. We'll log all of those. Thanks for taking part in the surveys. We'll make those available as well. Yeah, hopefully we'll send, you'll get we've got all your emails, so we'll send through the PowerPoint. You'll have all the links to explore the specification. As I said, really, the next month is the consultation, so you tell us what's wrong and we'll try and fix it. And we've got 3 more sessions over the coming months, so yeah, really encourage your participation in those. And thanks for your time on the call today. Speak soon.
Thanks, Adam.
Thanks, bye.